I want to introduce Kevin Vowels. He has a PhD in clinical psychology and has worked at the National Health Service in the United Kingdom, as well as serving on the faculty at the University of New Mexico in the Department of Psychology. He's published extensively in the field of assessment and rehabilitation of individuals with chronic pain. He's going to talk about the psychological perspectives on disability and rehabilitation in chronic pain. Here's Kevin.
Thank you very much. Can you all hear me okay? Yeah. All right. So I thought, thank you for the very kind introduction, the kind invitation to come here and speak with you all today. Thank you to you all for attending and spending your lunch with me. I'd like to maybe just get started and find out a little bit about disciplines in here. Generally, I ask people to do this without food on their lap, so this is a double challenge to correctly identify your discipline and do it without spilling your lunch. So how many physicians do we have in here? All right, clinical psychologists? A couple of us shrinks around, good. Social workers? Outstanding. Nurses? PTs? Any PTs? One PT? No. Oh, nurse, I was gonna get there, don't. OTs? Nurse practitioners? Policy people? Cool, all right. Anybody that I missed? Pharmacy folks? Cool, welcome. Awesome. Addictions counselors and counselors, awesome. So one of the nice things about being the only psychologist on the panel, as far as I know, is that I have the luxury of speaking for the field, and nobody can disagree with me up here. It's wonderful. What I'd like to do today is just give you a bit of an overview of my understanding of what psychologists do in the treatment of chronic pain, or the rehabilitation, as it is perhaps more accurately referred to, or as I prefer it referred to, of chronic pain. I'm going to start by just giving a bit of a broad overview of pain, and some of that will be redundant with the wonderful talks we've already had today, so I'll probably move fairly swiftly through that. And the meat of what I'd like to talk with you about is what exactly are psychologists doing, or what do we want to do in chronic pain? Maybe what, as a field, ought we to be thinking about when we're thinking about the treatment of chronic pain? And then I'm going to conclude with talking about the data and what the data suggests seems to work reasonably well in chronic pain. I'll start just by noting I don't have any funding from commercial organizations or industry. Some of my research has been funded by various external funders, both here in the US and in the UK. I can't, for the life of me, I can't identify any conflicts of interest from these external funders which would influence my presentation today in a way where I try and convince you of anything. I'll start with what is potentially a radical idea in some circles, although I would assume less of a radical idea here, particularly given the talks that have come already this morning. And that idea is this, that for the vast majority of individuals who have chronic pain, pain intensity can be viewed as a fundamentally untreatable symptom. And when I mean fundamentally untreatable symptom, that's kind of exactly what I mean, which is that the vast majority of individuals, or at least a significant proportion of them out there, who've had chronic pain for longer than 3 or 6 months are likely to continue to have pain forever. And I'm not necessarily here to debate that point with anyone here today. I will if you want to, but the data suggests that pain is remarkably persistent, right? And we probably all know this. Just ask you to consider what we know about chronic pain. We know it's incredibly common, somewhere between 1 out of every 3, 1 out of every 5 adults out there in the wild is experiencing chronic pain at this moment. We know that it remits in only a minority of cases. The longest follow-up study that I'm aware of is the study of Gerhard Anderson here, which was a 12-year follow-up study. Individuals were called at the onset of the assessment, asked if they'd been experiencing pain daily for 6 months. Those individuals who said yes to that were then called again 12 years later. Anyone want to guess what the proportion of individuals who had chronic pain at day 1 was at year 12? 86%. And that data is fairly consistent with shorter-term follow-up studies. The one of Elliott et al. Here was a 2-year follow-up study. If I recall correctly, there's a Garej et al. Study that's a 1-year follow-up. So pain tends to be persistent. And finally, as both Dr. Lozier talked about this morning, as well as Penny, there is not a whole lot in our quite vast and sophisticated clinical armamentarium that seems to reliably reduce pain over the longer term. Excuse me, I'm getting a phone call, which this is an inappropriate time. It's my wife, isn't that nice? Lost my train of thought. There is not a whole lot of evidence out there for durable pain reduction that is both durable, that persists, and is problem-free. We know this, that opioids is. Having lived in the UK, I know exactly what a dog's breakfast is. I've heard a number of times the opioid literature, as Dr. Chu talked about, is an absolute mess. We know that continued pain and disability are the norm following surgery. We know that implantable devices such as spinal cord stimulators are expensive and at best related with transient reductions in pain and no durable improvements in functioning whatsoever. For those of you who read this literature, I would encourage you to look at this series of studies by Kemmler et al., the first one published in New England Journal of Medicine in 2000, compared spinal cord stimulator implantation plus physical therapy versus physical therapy alone. Up through 2-year follow-up, spinal cord stimulation was associated with lower levels of pain intensity than physical therapy alone, but not related with or not associated with any differences in functioning or quality of life. Those differences in pain were absent 3, 4, and 5 years post-SCS implantation. I try not to be a morose individual, but I worry that treatments such as this, which are highly expensive, as far as I can tell, about $100,000 for surgery suite and short-term follow-up, allow people to feel more comfortable while they're sitting on their couches. And I don't know that those are the outcomes that we're looking for. Epidural steroid injections, the story is much the same, a fairly common treatment, at least historically, for pain here in the US. The American Academy of Neurology commissioned a set of clinical guidelines, which was published in Neurology in 2007. The findings of this committee suggested that epidural steroid injections were probably not effective for low back pain, for lumbar pain, in terms of long-term pain relief, improvements in function, or decreasing rates of surgery. That probably not effective was the lowest grading of evidence, or the second lowest grading of evidence, excuse me. The only thing that was lower was not effective, okay? For cervical pain or neck pain, the committee found no evidence whatsoever upon which to base a recommendation. In the United Kingdom, there's a socialized healthcare service, as many of us know. One of their institutes is responsible for commissioning healthcare interventions. It's called the National Institute of Clinical Excellence, or NICE. And it is data like this that led NICE in their latest recommendations, which are about 6 or 7 years old now, for low back pain to say no more epidural steroid injections, except in very carefully selected cases. Not because they're too expensive, not because we don't want to treat people, but because they don't seem to be doing what we want them to do. So I have a question. If it's not pain that we're treating, or if we don't have a lot in our armamentarium that effectively gives us durable pain relief, what are we treating? And I have some ideas here, and I'll just start with an excerpt from a patient letter. I used to do a small amount of legal consulting work, and those of you who do legal consulting work, you know the drill. You get this thick file, you look through it, and try and say something smart at the end, right? As I was looking through a file a number of years ago, I came across a handwritten letter that a patient had written to her physician, trying to explain to her physician what the experience of pain was like for her. Perhaps some of you have gotten these letters in the past. And there were a number of things that she said in there that were noteworthy to me, that really struck a chord in terms of trying to clearly highlight what it is we're treating when we're treating pain. Here's some of the things she said. She said, I'm trying to do more to take the load off of my husband and my daughter. She said, if there are no carers and I'm bad, I don't wash, I don't eat, I don't take care of these very basic needs. For those of you who know your psychology, your historical psychology, these things that are very low on Maslow's hierarchy of needs. She says, the pain's okay, but I got this other weird stuff going on in my chest and my arms, and it's kind of starting to freak me out. She says, I can cope with the pain, but I'm starting to fall, and that's dangerous. She says, the house is a mess, my husband is stressed and depressed, and my daughter stays away. And she concludes the letter by saying, I'm very positive and cheery. Now, we could probably debate the accuracy of that particular statement, but she says, I'm worried it's not doing me any favors because people think I'm not as bad as I really am. And here's the thing that struck me about this, and maybe you've noticed this too. There's a number of targets for treatment up here, right? A number of important targets for treatment. Improving family life or social functioning or just her ability to do self-care or keep her house clean. Not a single one of those treatment targets is pain intensity. In fact, she says it's okay. And you'll just have to believe me that the rest of this letter was not littered with statements of pain's horrible, pain's horrible, pain's horrible. It wasn't, all right? There's a clear request in here, if we're looking for it, of what it is we need to alter with our treatment technologies. Another thing, I try and be a good scientist, or at least adhere to what the data says. And when presented with questions that I don't know the answer to, I do what any good scientist does, which is I go to Google and type some stuff in and see what happens. This is a slide I generally reserve for when I'm talking to members of the public who might have chronic pain to try and illustrate this point of what it is we're trying to treat. Searching for two very specific statements. I just want my life back. That's something I hear a lot in my clinical practice. People say, look, this pain has destroyed my life and I just want to get back to a reasonable level of functioning. Searching that with chronic pain, and then a statement that at least I don't hear a whole lot in chronic pain, in my treatment, maybe because I'm the shrink or maybe because I don't ask if people just want the pain to go away. But this other statement that maybe stereotypically we would think pain patients might say, I just want this pain to go away in chronic pain. This is in no way a scientific study at all, is it? But the findings, nonetheless, I found to be a little bit surprising. Maybe you will as well. 1.4 million hits for that very specific statement paired with chronic pain. And I looked through a small number of them, by no means a representative sample, but each one of them said exactly the same thing or was implying the same thing, which was this pain is really messing stuff up and I just want to get back to the business of living. All right? With regard to I just want this pain to go away, about 4,000 results. And I don't know if that's a meaningful difference or not. I don't know if I searched under the wrong term or not. Okay, maybe I've searched the wrong sentence. But that is a big difference in terms of what people are asking for on the internet. And this is the God's honest truth. The very first one that came up was a guy who said, I just want this pain to go away enough so that I can get back to the business of living. So here's a model of pain and suffering. Dr. Lozier this morning talked a little bit about suffering, and Penny did as well. She implied it a number of times. Here's a model of pain and suffering, and the model is this: pain leads to suffering. And everybody knows that model. It's not a controversial model. Our patients know this model. They know the experience of pain is causing disruptions to their life. If you want to test this model yourselves today, I would encourage you, if you see a small child walking down the street, to trip them, induce some pain, and see what happens afterwards. And our patients know this model too, okay? And they know if pain is causing suffering, all I got to do is reduce the pain and I'll reduce the suffering. And yet I've just talked about how hard it is to do that durably, and in fact the entire morning, as far as I'm concerned, has sent this same message. It's an incredibly hard thing for us to do when people are experiencing persistent, durable, long-term pain. We have some evidence that pain patients will say, or people with pain, will say the struggle with pain is important to them. It is important to keep fighting this good fight. It's a study we published years ago where we were trying to develop a questionnaire of how much people were fighting against pain or how willing people were to experience pain. One of the items on here was this: how important is it to keep fighting this pain? The vast majority of patients said that it was always true or almost always true. 92% of them said, yeah, it's important to keep fighting this good fight. In fact, from a questionnaire development perspective, this item was no good because there was no variability in the patients. Everybody said, yep, important for me to keep fighting this fight. Here's the problem with this fight. Individuals who say they are frequently engaging in a struggle to control pain or are spending a lot of their time fighting with pain tend to be the worst off. Right? We have a questionnaire where we have a variety of different behavioral responses to pain listed on there, and we ask individuals to tell us how many days out of the past 7 they've engaged in one of these responses to pain at least once on the day. And it's a mix of things we might say are adaptive or good behaviors, like using strategic rest or asking for help or doing something that matters, to things that we might think are more problematic, like having a smoke or a drink or going to bed. And there's one item on there which is how many days out of the past 7 have you struggled for pain control? And when we look across all of these items at the item level, that struggle for pain control item is the single best predictor of more pain poor activity. Worse activity, more emotional distress or dysfunction, more pain-related fear and engagement and avoidance behavior, more healthcare utilization. And we've looked at this particular item or this set of items in a variety of different circumstances in adults, in adolescents, in older adults. We've looked at it cross-sectionally, longitudinally. We've seen if we can change it over the course of treatment. And it seems to be one of these reliable findings that if people are spending a lot of their time fighting with pain, they tend to be in trouble. So it's not that this model is incorrect. It's just that this model might not quite be adequate when it comes to driving treatments or identifying treatment directions. And here's a different model, and if you've hung out with psychologists long enough, you'll know that models that only have one arrow make us a little bit nervous. So I don't know if this is a better model or not, but it's got more arrows, so I can breathe a little bit easier. Anyway, let me walk you through the model. We've got a few things going on here. We've got pain. We've got pain sitting out there, and pain is doing what pain will do, which it is contributing to some degree of suffering. And I would say that that relation between pain and suffering, that direct relation, is hard for us to manipulate clinically. Down in this other circle, we have responses to pain. We have responses to pain. Okay, we have spending a lot of time struggling to achieve pain control. And what the data seem to suggest, again, is spending a lot of time struggling for pain control tends to meet with failure. And the long-term effect of that can be losses in freedom and opportunity, and the ultimate effect of that can be an exacerbation of suffering. So are there things in here that we might be able to change with our clinical technologies or our clinical interventions? Here's two options. We might be able to alter struggle with pain, get people fighting pain a little bit less. And we might be able to get people more engaged in the stuff in life that matters. And I think that's what this is. We might ask them to maintain a life direction, any life direction, things that matter to us, social functioning, relationship functioning, answering the phone when your wife calls you, childcare, productivity, education, any of these kinds of things. These matter to humans. And the thing with the maintenance of life direction is that the success is in the maintenance, all right? And I'll give you an example here. This is not to say every time we engage in something important that we will naturally meet with success, but it's about a persistence in activity over time. So I'm a father. I have a 10-year-old daughter. She's cool. I like her a lot. But that does not mean I'm always exactly the kind of father that I want to be. Parents, do you know what I'm talking about? 3 o'clock in the morning when they're young and puking all over the place, right? Not always exactly the kind of parenting behavior that I want to admit. Okay, but it's about the maintenance and the persistence in that behavior over time. And that maintenance and persistence ought to allow for broader opportunities, for increases in opportunities for engagement, increases in opportunities for meaningful, valued, fulfilling activities. All right, and what this might do is allow us to reduce suffering. And you will see there is one thing that has not changed here. Okay, maybe we might change pain reports, but that's not the objective here. Okay, the objective here is to get people functioning in here. One of the first studies we did to try and alter this struggle experimentally involved a set of, I think, about 90 low back patients, 90 patients with low back pain. We asked, what we wanted to do was to see if we could experimentally manipulate how much they were fighting with for pain control. And we took one group of participants and asked them to struggle more with their pain, try and get better pain control. And another group of participants, we tried to get them to struggle less with pain. And I'll tell you more about that in just a second here. Oh, there it is. We assessed physical functioning using a set of activities that's called the Physical Impairment Index or the Physical Impairment Scale. It's a set of flexion, extension, straight leg raise type activities that are generally done by a physical therapist. You measure range of motion with a goniometer. And the thing about this measure is that it's got norms for disabled or not disabled. So you can measure flexion and extension, and you can quantify those as a 0 or a 1 is someone's range of motion in a disabled range or in a non-disabled range. And that allows you to score physical impairment on a 0 to 7 scale. Higher levels of impairment or higher scores on this indicative of higher levels of dysfunction or disability. So everybody did that with no set of instructions. We then asked these individuals to listen to one of 3 sets of audio taped instructions. The first, we said, research has suggested that if people really try and get their pain under control mentally, they can do it. We were under no obligation to tell the truth. That people can do it, all right? And we're going to ask you to do these physical movements again, and what we want you to do this next time is keep pain lower. And what research has also shown is that if you're able to do this and keep pain lower, you can perform better on these tasks. So please keep pain lower and perform better, all right? Does that make sense? Second set of participants were asked to struggle less with pain and essentially let pain be and try and improve functioning. So don't let pain make the decisions for you. You make the decisions for you in terms of how much activity you want to do or not do. And what research has shown is that when people can do this, they can increase performance. The third group was a control group of sorts, and we called that a continued practice group. And the audio taped instructions said to them, whatever you did the first time, keep doing it. And what research has shown is that if you keep doing the same thing you've always done, you're going to increase performance. All right? And then we had them do that physical task again. And I'll show you, these are the findings only for the struggle less and the struggle more group. This is our measure of physical impairment here. I will point out to you that it's a truncated scale, all right? So it only goes from 3.8 to 5.4. What we saw from this 2-minute set of audio taped instructions was a pushing apart of physical impairment or of physical performance. Where the individuals who were asked to struggle less had lower levels of physical impairment. The folks who were asked to struggle more had more levels of physical impairment. And this did reach statistical significance. We assessed pain intensity for all tasks at both time points, and at no point was there a difference in pain intensity ratings. What this suggests is two things. One is that at least at an experimental level, we might be able to alter the degree to which people are fighting for pain control. And when we do that, we might be able to influence performance. In addition to that, this is not just a matter of something we might say of accepting pain. The brand of psychotherapy or the type of behavior change therapy that I practice is called acceptance and commitment therapy. And I won't talk a whole lot about the various brands because psychologists can go to war over those kinds of things. But the acceptance part has sometimes not done us a lot of favors because it suggests what we're trying to get people to do is just accept it. You ever try that intervention with a person with pain? Just accept it, man. Generally doesn't go too well. So this is not a matter of just accepting it. In addition to just accepting it or increasing willingness to have it, we might try and uncover with individuals why in the world they'd want to accept it. What are the important purposes in life that they could pursue or that they want to pursue and that they are willing to do in the service of increased pain or in the service of continued pain. This is a study published by a group in Wisconsin, if I recall correctly. It is an experimental study done on undergraduates with transient pain. And so let's remember what the very wise Dr. Lozier told us this morning, which is that transient pain has little to no relevance to the treatment of chronic pain. I'd ask you to keep that in mind as I show you these data and see whether or not there might be some relevance perhaps here to our patients that we see. This experimental study followed a time-honored tradition of bringing undergraduates into the laboratory, doing some kind of manipulation to them, and then hurting them, and kind of seeing what happens. Maybe you've done some of these experiments yourself, or maybe during your undergraduate years you were a part of one. For this particular experiment, they used something called a cold press or an ice water bath, which if you keep your hand in an ice water bath long enough, it starts to hurt, all right? Nice thing about a cold presser is it has low risk of tissue damage, so people can maintain immersion in that ice water bath for a fairly prolonged period of time with no risk or minimal risk of some kind of tissue damage occurring, but it does hurt. They assigned these undergraduates to one of three experimental conditions. The first was an attention control condition. Individuals assigned to that group were read from the state constitution of Wisconsin for 30 minutes. You can decide for yourself whether or not that was truly an inert control condition or not. The second group was assigned to what these experimenters called a pain acceptance group. And at this point in time in the literature, back in 2009, what was a fairly well-established finding was that if you do acute pain or transient pain experiments and you ask people to be more willing to have pain, to not let pain make the decisions for them, all this stuff I just told you about our low back pain study, that in general, individuals were able to remain in contact with that aversive stimulus for longer. All right? If they were fighting with it less, they could stay in contact with it longer. They then did something that I think was very clever. They added on a values manipulation here. And the way that they described the values manipulation in the study document was when these undergraduates were brought in the laboratory, they just asked them what kinds of things mattered to them in life. What kinds of things are important to you? What activities matter? And an example that they give is if the undergraduate said, my family is important to me, they said, okay, we're about to ask you to put your hand in this ice water bath, and while you're in contact with this aversive stimulus, we'd like you to imagine that you remaining in contact with this aversive stimulus would somehow allow you to better engage in some kind of meaningful activity with your family. For example, imagine as you're doing this that there's a family member of yours who's gotten themselves into trouble in one of the many cold lakes they have around Wisconsin. And you getting into that lake and exposing yourself to pain would allow you to render some aid to your loved one. Make sense? But I think a pretty clever manipulation, but also let's bear in mind that this was this experiment was presumably offered under informed consent. There was no family member in distress. There was no lake. And that they knew that they could withdraw their hand from the ice water bath at any time. All right? The primary variables they assessed, which are fairly common in studies of transient pain or experimentally induced pain, were pain threshold, the point at which people said it started to hurt, pain intensity, and if I can recall correctly, this was pain intensity when the hand was removed from the ice water bath, and then what may be the most important measure here, pain tolerance, so how long these individuals remained in contact with that aversive stimulus. Here's what they found. No significant differences in terms of threshold across the three groups. All of them said it started to hurt about 20 seconds. Pain intensity, they saw evidence of some difference in pain intensity. The different letters here indicate statistically significant differences, such that the acceptance plus values group had more pain than the attention control group. When they looked at tolerance time, however, a fairly remarkable pattern of differences was apparent. Such that, isn't that interesting? Oh, I wish I thought of this study. Oh, man. This, and these are average effects, okay? There's individual variability in here. This effect, again, fairly well established in the literature. You add a little, like, let's make room for pain here, and let's see if we can be willing to have it. About a doubling, on average, of tolerance time. But you add a reason to remain in contact with it, an important reason to remain in contact with it. On average, you get another doubling. And I wonder about our patients when it comes to stuff like this. Within behavior change treatments for chronic pain, there is increasingly a focus on these things we might call values, defined in a similar way as that Brandstetter-Rost study that I just presented to you. The stuff that forms the answer to questions like these. What kind of stuff in life matters to you? What kinds of stuff brings meaning to your life? And if you're given a presentation on values, you can go as crazy with the clip art as you want to. But oftentimes, this involves things like friendships, romantic, intimate, or even close interpersonal relationships, caregiving behaviors, productivity behaviors, independence behaviors, self-development kind of behaviors. There are all sorts of options here. And this is a non-inclusive list of some of the things we might say matter to human beings. And as you look at this, my guess is there's probably something up here that, at least one or two things that matter to you. And here's what we know from the literature. If we can get less struggling for pain control and greater engagement in valued living in patients who have chronic pain or in people who have chronic pain, we know that individuals who have more willingness, more engagement in valued activities now have better functioning right now, better physical and emotional functioning right now. They also have fewer pain-related medical visits. We know individuals who are more willing and more engaged in valued activities now are going to have better functioning in the future. And we know, and I'll walk you through some of this in just a second, we know if we can design treatments that are designed to enhance willingness and get behavior change in the direction of valued activities, that changes in willingness and engagement in valued activities are associated with greater levels of improvement in functioning. The longest follow-up study that I'm aware of at this point in time is a 3-year follow-up study. We published this study in Behavior Research and Therapy in 2011. A 3-year follow-up after an interdisciplinary course of rehabilitation designed to do exactly this stuff. There was minimal loss of treatment gain from the program. And that's a funny way of saying people still looked about as good 3 years out from treatment as they did 3 months out from treatment. The only areas where they weren't as well were pain intensity. That's okay. and I'll show you these data in a second, and also physical disability. And I'll show you the data in a second, because the loss of improvement in physical disability is of some concern. That happened within a context of maintenance of gains across a variety of other variables, but certainly something for us to keep in mind. So potential model of treatment. If we get this, then that might get us this. The rehabilitation programs that I was involved with in the UK and that we are in the business of trying to set up in New Mexico, and theoretically we start hiring people on Monday. But as I've joked with people, I haven't seen a bank account yet. These are interdisciplinary rehabilitation programs consisting of at least physical therapy, clinical psychology, and some kind of healthcare professional, traditional one, a physician or a nurse practitioner or a nurse or some combination of them. Treatment programs are explicitly about willingness and values. The treatment outcomes that we are seeking to get are that. And what we assume is that we don't need to make people feel better to achieve that. We don't need to reduce their pain to achieve that. It's not that we don't care about pain or that we don't care about how people feel. It's that effective and valued living does not require as a prerequisite low pain or feelings of happiness. The programs that we offer tend to be fairly intensive. The least intensive program that we offered was about 6.5 hours a day of active treatment content for 4 weeks. Other programs that we've done have been 6.5 hours a day for 5 days a week for a period of 3 to 4 weeks. So these are programs that used to be around here in the US, right? And we all know that they weren't around as much during the 90s and early 2000s, but they're starting to be a bit of a resurgence. We might say these are interdisciplinary rehabilitation programs. I want to show you some within treatment data because I hope it's of interest to you. We asked patients in this 4-week program to complete a diary every week, telling us about various aspects of functioning. We tried to get them to do it every day, but sometimes people who have chronic pain and are in treatment don't listen to you and don't do what you want them to do. Don't know if you've ever noticed this. And so they weren't very compliant with completing the diary data, so we decided once a week was okay, and they were able to do that. This was filled out at the midpoint of each week's treatment. So the end of day 1, the beginning of day 2, and these 2 days a week were contiguous with one another. We asked them about pain intensity. We also asked them about distress, and if there is time and or interest. I'll tell you about some analyses we've done in a cohort of 175 patients, which suggest trajectory of change over the course of treatment in pain and distress. In other words, if pain goes down or it goes up, or distress goes down or goes up, that those trajectories of change have nothing to do with 3-month treatment outcomes at a statistical level. Nothing. But enough on that. We also asked them about struggle or willingness to experience pain. How willing were you to have pain and distress in the past week? How much effort did you put to making pain or upsetting thoughts, feelings, or memories go away? This past week, we reverse scored that one. We reverse scored the willingness one. And what we assume is that successful treatment ought to involve a decrease in struggles for pain control. We also asked them about engagement and valued activities. How effective were you in taking action that contributed to a better, more vital quality of life over the past week? How effective were you this past week in making progress in the areas of your life that matter? And we would assume successful treatment ought to involve an increase in this, right? We don't really know. We assume pain will do something. It might move around. But that successful treatment will not necessarily involve a decrease in pain. I'm just going to show you the data from 3 patients. And we have a cohort of data on this, but I think these 3 patients illustrate the options here. This is a woman in her 40s who had fibromyalgia. We've got our 4 weeks of treatment down here on the x-axis, 3-month follow-up here. We've got our 0 to 10 ratings here. Here's what happened with pain and distress over the course of treatment. It moved around. That's okay. Here's what happened with struggle. Over the first 3 weeks of treatment, it really spiked up, such that by week 3, she was at the maximal level of struggle. She was really having trouble with pain and distress. This would be a concern if it stayed up over the course of treatment, but it is also not necessarily an unusual occurrence in treatments such as this, that as people start to come into contact with things that they've been trying to avoid, sometimes for years or decades, it has an impact on them, right? So if it had stayed up, we'd be worried, but that's not what it did. It dropped right down such that it was at 1 at 3-month follow-up. With regard to engagement in valued activities, that went up over the course of treatment, stayed up at 3-month follow-up. And as we looked at this graph, we said to ourselves, this ought to be a picture of treatment success. All right? Struggle went down, engagement in valued activities went up. We looked at outcomes at 3-month follow-up, levels of disability as measured by a measure called the sickness impact profile, 163 items of disability. There was a reliable decrease in disability. By reliable decrease, what I mean is that the change that was observed exceeded change that could be accounted for by measurement error alone, if that matters to anyone. So it's a bit of a stringent way of trying to look at change. Engagement in valued activities, or the discrepancy between important areas in her life and how successful she said she was in those areas, had decreased from 70% discrepant to 25% discrepant. Number of pain-related medical visits in the previous 3 months had gone from 5 to 0. So it's hard for us to say, hand on heart, this is definitely a treatment success, right? We don't have a clear marker of treatment success in chronic pain, but I would suggest this looks like a reasonable outcome, at least at a short-term follow-up. There's another individual, this was a gentleman in his 50s who was a teacher who had to quit work because of the recurrence of chronic pain. If you look at that pattern there, we see in red that pain dropped a little bit, that's fine. But struggle dropped down nicely. Engagement in valued activities went up, not quite as dramatically as the first individual, but still we have this X function. When we look at 3-month follow-up, pain had come back up a little bit. Struggle had dropped right down. Valued activity had gone right up. Again, if we looked, as we looked at this, we would say this ought to be a picture of treatment success. When we looked at our 3-month outcomes, a similar picture as the first one, a reliable improvement in disability, a decrease in discrepancy, not quite as dramatic as the first individual, but a decrease nonetheless, and then a very nice decrease in pain-related medical visits from 3 months prior to treatment to 3 months following treatment. These are the data that we marched out when we talked to funders. And of course, treatment is not always successful. This is a pattern of an individual who we were worried about at the end of treatment. Because struggle stayed high and all the values came up, it was in this context of a lot of struggle for pain control. We looked at 3-month follow-up, struggle remained high, engagement in valued activities dropped right down. And when we looked at outcomes, this looked like an instance of treatment not doing what it was supposed to do, of not helping this man get back to the business of living. We've recently published a small cohort study of 28 individuals tracking change over the course of treatments in this area and determining how good this pattern of change was at predicting outcome. And to make a long, somewhat complicated story short, if we observed this pattern of change in treatment, a lack of change in struggle for pain control, or a lack of change in engagement in valued activities, that was 80% predictive or 79% predictive of a lack of reliable change in disability. If we observed that change, it was associated with, I think, an 81% or something like that. If we observed changes in these things, it was associated with 81% degree of accuracy with reliable change in disability. All right, a small cohort, certainly a lot of work to do, but at least supportive of the hypotheses. We've published our outcomes as much and as often as we can. I'll show you a couple of broader outcomes here. This was a cohort of 150-ish patients through 1-year follow-up. Our outcome measures are here. This is our pain willingness measure, a longer measure than that diary one. This is that discrepancy between important and valued activities. Disability from the SIP, depression from the British Columbia Major Depression Inventory, pain-related fear from the Pain Anxiety Symptom Scale, and that pain-related medical visits in the preceding 3 months. All outcomes here have been converted to effect sizes. Many people in this room probably know what effect sizes are. For those of you who don't, effect sizes convert units of change in units of raw change into units of change in standard deviation. All right. So an effect size of 1 at the end of treatment would suggest between your 2 time points, the average change was 1 standard deviation on a measure. By convention, because this old, very well-respected statistician named Jacob Cohen said we should do it this way, we call a small effect size an effect size of from 0.2 to 0.5. Colloquially, that's a difference that really only a trained eye or a highly informed observer would be able to detect. A large effect size by convention, I'm sorry, this error bar has moved a little bit. A large effect size is 0.8 or above. Again, colloquially, that's a difference or a change that even an untrained eye would be able to detect. Medium effect size is 0.5 to 0.8. Across the psychological intervention literature writ large, most of our interventions get us about a medium effect size. That's fairly true as far as I can tell across a lot of interventions in healthcare in general, and certainly in pain as well. If you just eyeball these, you see in general, medium to large effect size across these various outcomes. Reasonable maintenance of treatment gains at that 1-year follow-up. In some cases, an increase in the effect size. In some cases, a decrease in the effect size, but reasonable maintenance of treatment gains. From the more intensive program that I was a part of in Bath, where we had those 3-year follow-up data that I talked about earlier, we published those outcomes again in 2011. This is that same effect size graph. It's just now turned on its side because we thought that was a good idea. Rather than keeping it vertically. Again, if you in the solid line here, we have the effect size at 3-month follow-up. In the dashed line here, effect size at 3-year follow-up. Again, and we've got our large, medium, small effect sizes here. Again, if you eyeball this, you see in general a medium effect size at 3-year follow-up. The only exceptions, as I mentioned earlier, were for pain intensity and also significant loss of treatment effect for physical disability, where it went from a medium effect at 3 months to a small effect at 3-year. And I'm not sure exactly what to make of that within the context of reasonable maintenance of treatment gains across the other measures and a non-statistically significant decrement in functioning. But there it is, certainly something for us to keep an eye on. So in summary, we have the clinical technologies available to us to enhance willingness to experience pain in the service of the stuff that matters. We can also use our clinical interventions to foster a behavioral commitment to move towards what we desire or what we want out of this life with those ongoing aversive experiences. This is my understanding of this therapeutic approach, which is merely the latest instantiation of the behavioral approach championed by Fordyce, particularly well put in his book published in 1976. ACT is a direct descendant, I would say, of those good old behavioral interventions. The American Psychological Association's Division of Clinical Psychology maintains a list of research-supported treatments or empirically supported treatments. And to be evaluated for this list entails the review of an entire literature of outcomes by an impartial committee of individuals who are tasked to make a determination: does the data support the effectiveness of the intervention? There are 3 primary levels that can be given: no evidence, modest evidence, strong evidence. There's a 4th one, which is controversial evidence. It's not really the one you want to be in. ACT for chronic pain has, I'm sorry, this is a little small, has strong research support. That's the highest possible grading. It was given that, I think, 2011, 2012, not too long ago. These are the criteria to meet this standard. In order to meet this standard, several research groups who are non-overlapping must have conducted several studies, so contributed to a body of literature. The results of this treatment outcome literature must converge to support the effectiveness of the treatment and must not contain fatal flaws. At the time of this grading being given, there were at least 4 groups out there who were doing treatment outcome stuff in this area. There was our group, a group from the University of California at San Diego, and then 2 Swedish groups. This literature has grown over the ensuing half-decade or so. So, I don't think this first statement will be a surprise to anyone in this room, and at least some patients, at least some of the time, pain is not the primary problem. And that statement in many ways is me being scientifically conservative. I would say in at least a significant proportion of the patients, at least a significant proportion of the time, pain is not the problem. The problem is that behavior has quite naturally been directed towards ineffectual pain control behaviors, or pain control attempts have dominated behavior, and that this has come at a cost. And the cost is engagement in the things that actually matter to the folks, engagement in family, social, recreational activities that bring meaning and quality and vitality to living. And we have treatment methods that can directly target these losses and restrictions in living. We have treatment methods that can work towards facilitating willingness to have aversive experiences and the service of the stuff that matters. We can measure treatment outcomes in terms of successful living, not in terms of how someone is feeling. Bill Fordyce, who we already heard about this morning and is an absolute hero of mine, wrote in 11 words what it's taken me like 53 minutes to get to. And here's what Fordyce said in a paper he published in the American Psychologist. In fact, Dr. Lozier already said it. People who have something better to do don't suffer as much. This is a wonderful paper if you are interested in this literature. Fordyce published it in '88 in the American Psychologist, based on a lecture he delivered in '87 at the annual conference of the American Psychological Association. So all that's left for me to do is to, as I did this last night, it's the same joke. I'm sorry for those who were here. Last thing I got to do is show you a picture of my daughter because she's cute. Give you my contact information. I'm more than happy to field questions or concerns or areas of disagreement. And finally, just thank you very much for your attention. Thank you very much.